Welcome to This Week in Obstetrics and Gynecology. This week we're covering 10 notable papers spanning maternal mortality and postpartum consequences, the strengths and limits of obstetric ultrasound and Doppler, menopause care in complex patients, and reproductive medicine and gynecologic surgery. Let's dive in. We start with maternal mortality, where Obstetrics and Gynecology published 2 decades of Centers for Disease Control and Prevention pregnancy mortality surveillance system data covering 14,310 pregnancy-related deaths in the United States between 2005 and 2024. The headline is a sharp rise in the overall pregnancy-related mortality ratio from 2018 through 2021, followed by an equally sharp fall from 2021 to 2024, with an annual percent change of about -18. Most of that spike and its resolution tracked infection and sepsis, which rose steeply during the pandemic years and then fell by roughly half per year afterwards, consistent with the arrival and departure of COVID-19 as a driver. But 2 findings deserve your attention beyond the pandemic story. Cardiovascular conditions, including cardiomyopathy, were the leading cause of pregnancy-related death in 17 of the 20 years. And hemorrhage deaths have been climbing steadily since 2017, with an annual increase of nearly 7% that shows no sign of reversing. So the reassuring overall decline masks a hemorrhage problem that is getting worse, which argues for continued investment in quantitative blood loss measurement, massive transfusion protocols, and hemorrhage drills. That hemorrhage signal connects neatly to a nationwide Korean cohort in BJOG, examining what happens to women years after a severe postpartum bleed. Among 745,000 women delivering in 2015 and 2016, followed to 2021, those whose postpartum hemorrhage required red cell transfusion had roughly double the risk of premature ovarian failure before age 40. Postpartum hemorrhage without transfusion carried only a borderline, non-significant association, and there was a clear dose response, with risk rising further as transfusion volume increased to 4 or more units. This is registry data using diagnostic codes, so residual confounding, and possible unmeasured Sheehan-type pituitary injury or uterine artery embolization can't be excluded. Still, the practical message is straightforward. A woman who needed transfusion for postpartum hemorrhage warrants counseling about possible accelerated ovarian decline and a low threshold to investigate oligomenorrhea or menopausal symptoms in her 30s. Turning to imaging, 3 papers this week collectively ask how much we should trust what we measure. In the American Journal of Obstetrics and Gynecology, a prospective London cohort of nearly 12,000 singleton pregnancies at 35 to 36 weeks dissected what a late uterine artery Doppler actually tells us. Preeclampsia developed in just under 3%. Mediation analysis showed that placental growth factor accounted for around 40% of the link between uterine artery pulsatility index and preeclampsia, soluble FMS like tyrosine kinase 1 about 9%, and the ophthalmic artery peak systolic velocity ratio about 15%, while arterial stiffness measured by carotid to femoral pulse wave velocity contributed nothing significant. Critically, once angiogenic and hemodynamic markers were in the model, uterine artery Doppler was no longer independently associated with preeclampsia. In other words, in the 3rd trimester, the Doppler is a rather blunt proxy for placental angiogenic imbalance. If you have placental growth factor and soluble FMS like tyrosine kinase 1, the Doppler adds little. That conclusion is sharpened by a systematic review and meta-analysis in ultrasound in obstetrics and gynecology, pooling 26 studies and about 2,450 patients on the reproducibility of obstetric Doppler. Intra-observer agreement was reasonably good, with intra-class correlation coefficients around 0.88 for umbilical artery pulsatility index and 0.90 for mean uterine artery pulsatility index. But between observers, agreement fell. The inter-observer coefficient for umbilical artery pulsatility index was 0.68. And against strict reproducibility criteria, the overall picture was poor to moderate. For a measurement that drives delivery timing in growth-restricted fetuses, that is sobering. The authors argue for standardized protocols, multiple measurements per session, quality audits when outliers appear, and eventually artificial intelligence-assisted measurement. In the meantime, treat a single discordant pulsatility index with appropriate skepticism and repeat it. Ultrasound fares much better in the third imaging paper, a prospective head-to-head study of 463 women undergoing laparoscopy for suspected endometriosis, also an ultrasound in obstetrics and gynecology. With blinded sonologists and radiologists and the hashtag Enzian classification as the framework, transvaginal and transabdominal ultrasound following the International Deep Endometriosis Analysis Protocol matched magnetic resonance imaging across essentially every compartment. Ovarian endometriosis sensitivity, above 97%. Rectosigmoid deep disease, around 96%. The only statistically significant differences favored ultrasound, with higher specificity for tubo-ovarian adhesions bilaterally, and ultrasound showed slightly better exact concordance with surgical severity grading in the adnexa and bowel. This was a tertiary referral center with expert operators, so it is a ceiling rather than an average. But where that expertise exists, routine magnetic resonance imaging before endometriosis surgery is hard to justify. On the menopause front, Obstetrics and Gynecology published 2 narrative reviews that pair well. The first offers a symptom-based, risk-stratified framework for menopause in patients with cancer. Non-hormonal therapy is first line across cancer types, with the strongest evidence for serotonin and norepinephrine reuptake inhibitors, gabapentin, and lifestyle measures for vasomotor symptoms. Vaginal estrogen is effective for genitourinary syndrome of menopause, appropriate in most gynecologic cancers, and can be considered in selected breast cancer survivors after shared decision-making. Systemic hormone therapy remains contraindicated in hormone receptor-positive breast cancer, but may be an option in carefully selected non-hormone-dependent or low-risk gynecologic malignancies. The companion review on integrative approaches is usefully discriminating about what actually works. Cognitive behavioral therapy and clinical hypnosis significantly reduce vasomotor symptom distress and are recommended non-hormonal options. Mindfulness may help sleep and quality of life, but is not recommended for hot flushes. Acupuncture may offer subjective benefit. And phytoestrogens and botanicals, despite heavy patient use, lack consistent high-quality evidence and are not advised for routine symptom management given standardization and safety concerns. That is a specific conversation to have with the patient who arrives holding a black Kohash bottle. Finally, 3 papers on reproductive medicine and gynecologic surgery. In Fertility and Sterility, a retrospective cohort of 801 gonadotropin-stimulated, human chorionic gonadotropin-triggered intrauterine insemination cycles found that clinical pregnancy peaked at a leading follicle of about 16 millimeters and declined beyond 17. Pregnancy rates were 16.5% at 15 to 16 millimeters, 12.5% at 17 to 18, and only 6.1% at 19 to 21. Relative to 16 millimeters, the adjusted probability of pregnancy fell by about a third at 18 millimeters and by roughly 3/4 at 20. If you routinely wait for an 18 millimeter follicle before triggering, this retrospective signal suggests triggering earlier may be better. A second fertility and sterility paper, a multi-center cohort of 280 transfers in women with thin endometrium in Spain and Italy, tested intrauterine autologous platelet-rich plasma. It reliably thickened the endometrium, nearly a millimeter of gain versus almost none in controls, but after adjustment, it was not associated with biochemical pregnancy, clinical pregnancy, ongoing pregnancy, or live birth. That is a negative result on the outcomes that matter, and a reminder that endometrial thickness is a surrogate, not the goal. And in Obstetrics and Gynecology, a national analysis of more than 3 million weighted hysterectomies from 2016 to 2021 found that opioid use disorder was associated with about 18% higher composite complications after inpatient hysterectomy, more than a day of extra stay, and roughly 22% higher charges. In the outpatient cohort, the complication difference was borderline and not clearly significant. These patients merit deliberate preoperative optimization and a planned multimodal analgesia strategy. If you only have time for one paper this week, make it the Pregnancy Mortality Surveillance System Analysis in Obstetrics and Gynecology. It reframes the recent maternal mortality narrative. The pandemic-driven surge has receded, but hemorrhage deaths are rising and cardiovascular disease remains the leading killer, and that should shape where your unit puts its effort. Here are the key takeaways from this week in Obstetrics and Gynecology. First, United States pregnancy-related mortality has fallen since 2021, but hemorrhage deaths are climbing and cardiovascular conditions remain the leading cause. Direct your quality improvement accordingly. Second, transfusion requiring postpartum hemorrhage roughly doubles the later risk of premature ovarian failure, so counsel and follow these women. Third, late pregnancy uterine artery Doppler mostly reflects placental angiogenic imbalance and adds nothing once placental growth factor and soluble FMS like tyrosine kinase 1 are known, and obstetric Doppler reproducibility between observers is only poor to moderate. Fourth, expert ultrasound matches magnetic resonance imaging for mapping deep endometriosis and beats it for tubo-ovarian adhesions. And fifth, in intrauterine insemination, consider triggering at around 16 millimeters, and do not expect platelet-rich plasma to improve live birth in thin endometrium despite the millimeters it adds. That's your roundup for this week in Obstetrics and Gynecology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one, in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.